Good morning. Welcome to today's News of the Day press briefing. I'm Dr. Richard Shilsky, ASCO's Chief Medical Officer. I'll be moderating this morning's briefing. Just a few minutes, you're going to hear from the authors of 3 studies that will be discussed at the plenary session of today's meeting. I'll remind you that yesterday you heard from the authors of the 4th study at the plenary session, the Latitude study. As you know, the abstracts selected for presentation at the plenary session are those that the ASCO program committee feel are the most likely to be practice-changing and impact patient care. So joining me on the podium, and you'll hear from him in a minute, are ASCO President Dr. Dan Hayes, and then ASCO experts Dr. Hal Burstein and Dr. Nancy Baxter, and I'll be calling on them to provide some additional information and context about the studies being highlighted today. I'll remind you, as you file your stories, to please use our ASCO affiliations for purposes of attribution. So now I'd like to turn the podium over to Dr. Hayes for a few additional remarks. Dan?
Thank you, Rich. And thank all of you for being here early in the morning and helping us get the news out to our members, our patients, and the lay population in general. We are very appreciative. As I think most of you have seen over the last few years, the research you've heard about and that are being presented today really shows a remarkable diversity in advances for patients. We've seen advances in precision medicine, immunotherapy, and perhaps as important or more, reflecting the maturity of our field's survivorship. And 2 out of those 3 will be represented today at the plenary session. This progress doesn't come out by accident. Probably very few of you heard my presidential address, but it comes out of hard-won, well-done, highly respected research conducted by experts in the field, much of which is funded by the NIH. And so we're pretty proud of all that. We'd also like to thank those of you who are helping us disseminate this information. We really do appreciate and value your help in our doing this. It doesn't take just one of us. It takes all of us to do this research. And actually the theme of my entire presidency this year has been how ASCO makes a difference in cancer care with you. And with you is capitalized on purpose because you are a whole bunch of yous. Our members, our clinician scientists, our patients. ASCO really has a little bit of something for everybody. And again, I think the plenary session will reflect this. So thank you for attending and for helping us deliver this research around the world for people with cancer. We really do appreciate it. And we'd be happy to answer questions as the morning goes on. And with that, I hand you back to Dr. Shilsky.
Thanks, Dan. As you can probably tell, Dan's been a really inspiring leader for ASCO this year, and it's just been a joy to work with him. So on with the presentations. The first plenary presentation today highlights a pooled analysis of 6 phase 3 clinical trials. This is really a remarkable accomplishment that I'm sure Dr. Grothe will highlight, but 6 trials done all over the world, 12,000 patients, all pre-planned for purposes that you'll hear about in a minute, but a remarkable example of collaboration in order to answer a clinically very important and practical question, and that is whether 3 months of adjuvant chemotherapy in patients who have colon cancer that spread to the lymph nodes is just as good as the standard every 6 months of adjuvant, every 6-month course of adjuvant chemotherapy. So to present the findings from that study, I'm pleased to introduce Dr. Axel Grothe from the Mayo Clinic Cancer Center in Rochester. Axel.
Yeah, thank you for giving me a chance to present this late-breaking abstract one on behalf of the co-authors of the IDEA collaboration, in particular Dr. Shanxi, who is going to be the lead author at the plenary session presentation. When we go back to the treatment of stage 3 colon cancer, nothing had really changed since 2004 when 6 months of oxaliplatin-based therapy with FOLFOX or CAPOX, a capecitabine oxaliplatin versus 5-FU oxaliplatin regimen, had become standard of care with curative potential for patients. The problem that we're facing as clinicians and patients in particular is that longer duration of oxaliplatin-based therapy is associated with dose-dependent neurotoxicity. That's debilitating for many patients, short-term and long-term. It's nerve damage in form of numbness, tingling, pain, which can really persist for the rest of the patient's life. So shorter duration of treatment without compromising on efficacy would really be of benefit for patient and healthcare resources. So we started this academic collaboration more than a decade ago of 6 different trials, phase 3 trials conducted in 12 countries, really a worldwide effort to eventually include 12,834 patients with stage 3 disease, interrogating this duration question. And we needed this high number of patients to really have a precise estimate how much of efficacy we would compromise with a shorter duration of therapy and really have a so-called non-inferiority design of clinical trials. So this is where these studies were conducted, really truly a worldwide effort. Now, what we're really talking about here is balancing less toxicity and potential lack of a higher risk of recurrence. And the question is, of course, how much loss of efficacy, meaning anti-tumor efficacy, would we be willing to compromise for much better toxicity outcomes, lower toxicity? So which difference is acceptable? That's the non-inferiority question. So the studies, all of these studies, 6 studies with these 12,800 patients, randomized patients to 6 months of therapy or 3 months of therapy, and FOLFOX or CAPOX, the actual chemotherapy regimen, was up to the investigators and patients. This was not a comparison between these 2 regimens. And the objective was really to reduce side effects without giving up too much of efficacy. And when you put this into statistical terms in this non-inferiority design, you need to look at the upper limit of the hazard ratio, 1.12, and Dr. Shi will actually explain this in a plenary session presentation more and more. So anything that is below 1.12, with the upper limit of the hazard ratio, would be considered non-inferior according to our assessment, because we actually went to patient advocates and physicians and said, how much are we willing to compromise on outcome, potentially on outcome, for less toxicity? So these are the results. First of all, the toxicity. And you can see that for both chemotherapy regimens, FOLFOX and CAPOX, just highlighting on neurotoxicity, we have a dramatic reduction of neurotoxicity, about a third less of patients, or 3 times more toxicity when you use 6 months compared to 3 months, highly statistically significant. We know that 3 months duration is much less toxic. Now, what about efficacy? And we look at Kaplan-Meier curves for disease-free survival, and this is the outcome, 3 months versus 6 months, which seems to track very much on top of it. When you do the math, actually, we compromise, we kind of potentially reduce efficacy in disease-free survival by 0.9% at 3 years. Unfortunately, the hazard ratio crossed the upper limit of the hazard ratio crossed 1.12. So for all patients combined, based on the assessment that we made, non-inferiority was not achieved, but the difference in efficacy is very small. Now we come into clinical judgment. How much do we really take out of this? How much are we willing to push patients into 6 months of therapy for very minimal difference in disease-free survival? Also, we have 12,800 patients, so we could do subgroup analysis, pre-planned subgroup analysis, and I want to highlight 2, which I think are clinically relevant. Number 1, we divided patients into low-risk tumors and high-risk, patients with high-risk tumors, identified by tumors, T-stage, and lymph node involvement. And as you can see here, that the 3-year disease-free survival rate between the low-risk and high-risk tumors differs dramatically. It's 83% for low-risk tumors, 63% for high-risk tumors. And it was very clear to see that 3 months treatment duration was adequate for patients who had a low-risk tumor burden, meaning 60% of patients. So those patients should not receive more than 3 months of therapy, and that's the majority of patients with stage 3 disease. There was also an interesting treatment-related effect. It seems to be that 3 months of capecitabine oxaliplatin were adequate for all patients, independent of stage, where for FOLFOX, for the high-risk tumors, you needed 6 months of therapy, will be further explained in the plenary session presentation. So the IDEA group, comprised of investigators around the world, came up with a consensus statement, which I hope will make inroads into guidelines in clinical practice. I think it's in this how I have embraced my clinical practice. For the majority of patients with stage 3 disease, 60%, low-risk group, we do not recommend more than 3 months of adjuvant chemotherapy with an oxaliplatin-based regimen. For the higher-risk patient, I think we can make an assessment based on tolerability of therapy, patient preference, risk of recurrence, and the choice of therapy, how long we should push beyond the 3 months of therapy. That's really a discussion we can have with patients, and I think the IDEA collaboration really gave us the data to really provide a framework for discussions on risks and benefits for adjuvant therapy here. Shorter duration of therapy is clearly associated with a decreased risk of neurotoxicity. As I said, low-risk cancer, and this is the immediate consequence here. 60% of stage 3 disease should not receive more than 3 months of therapy with oxaliplatin-based regimen. That applies to 20,000 patients a year in the United States, and you can easily see that translates into hundreds of thousands of patients worldwide. There's not a direct comparison between these two different regimens. It seems to be if you're using capecitabine oxaliplatin, 3 months is adequate. Let me finish by giving some, I think, very important and notable facts. You already heard, IDEA represents an international academic collaboration that was conducted over more than a decade. It's by far the largest prospective study conducted in the history of colorectal cancer research. And it was funded by public funds and by philanthropy. There is not a company interest involved, and who's interested in shortening the duration of therapy from a commercial perspective? Those trials which have immediate impact for patient care, which are critical for patient care, can only be conducted with a publicly funded healthcare clinical trial system. And this is really what we stand for here, NIH and other mechanisms around the world that really contributed funding for the study. Thank you.
Thank you, Axel. So I'm going to ask ASCO expert Dr. Nancy Baxter for some additional comments and maybe to add some context to Dr. Grothy's remarks. Nancy.
Thank you. Thank you very much for your attention, everyone. This is a great day for patients throughout the world. What we've heard today is practice-changing work that shows for most people with stage 3 colon cancer, 3 months of treatment provides all the benefits of 6 months of treatment with fewer risks. Less is more. The researchers brought data together from 6 large randomized trials, including almost 13,000 patients from 12 countries, comparing 6 months of chemotherapy to 3 months of treatment, and found for most patients with lower risk disease, more treatment had no benefit. 6 months of treatment did, however, have more side effects, and some of these side effects will be permanent. Now, today, up to 60% of my patients with stage 3 colon cancer will be able to stop after 3 months of therapy and be able to get on with their lives and will have a lower risk of permanent problems such as numbness of their hands and feet. Proving we can give less treatment with the same benefit is a major advance for patients in our healthcare systems, but this type of work can only be done with federal funding. The pharmaceutical industry, as Axel said, is not interested in giving less treatment. This study is a great example of how NIH funding can have a major and immediate impact on the lives of cancer patients. Thank you.
Great. Thanks, Nancy. I might just add a couple of other slight comments. One, of course, is this whole issue about the neuropathy. Now, some of you may not appreciate the debilitating nature of this neuropathy for many patients, and it's important to keep in mind that it can be very long-lasting. It can persist for years after the chemotherapy treatment is actually completed. So this is not one of those side effects of chemotherapy that patients experience while they're getting the treatment, then it's over with. It can persist for a long period of time, and so, and it's related to the cumulative dose of the oxaliplatin chemotherapy. So the less of the chemo you can give, the less likely patients are to develop this neuropathy, the less likely it is to be long-lasting. And so that's a really important finding from this study. The other thing that I'm sure is not lost on all of you is that this represents another sort of step on the road toward increasing personalization of cancer treatment based upon risk assessment. So, we know that in almost every disease where we use adjuvant chemotherapy, not every patient needs the adjuvant chemotherapy because some patients are actually cured just by surgery. Not every patient benefits from the adjuvant chemotherapy. And then the duration of therapy is sort of arbitrarily determined based upon the results of large prospective trials. And so here we now are getting more sophisticated. We're being able to decide based upon a person's risk of recurrence what duration of adjuvant chemotherapy might be most appropriate for them. So I think we're going to see, I would predict, that beginning next week in clinic, patients are going to start being prescribed shorter doses, shorter courses of adjuvant chemotherapy if they have low-risk node-positive colon cancer. Sure, please, Dan, go ahead.
Because I've been asked this question, it's important for your readers to understand this is not chemotherapy versus no chemotherapy. These data don't mean that node-positive patients with colon cancer should not receive adjuvant chemotherapy. That's clearly beneficial and clearly reduced the odds of dying of colon cancer around the world. So this is less chemotherapy versus more. And I just want to make sure that that's clear.
Thanks. All right, we'll go on to our next presentation, which features findings from a large randomized clinical trial that assesses the impact of online self-reporting of symptoms by patients who are receiving chemotherapy and the impact of that patient self-reporting on overall survival. Dr. Ethan Bosch is the lead author. He's professor of medicine at the Lineberger Comprehensive Cancer Center at the University of North Carolina. Ethan.
Thanks very much, Rich. Good morning. On behalf of my fellow authors, as well as the patients and clinicians who participated in the study, I'm pleased to present the overall survival results of our randomized controlled trial assessing patient-reported outcomes for symptom monitoring during routine cancer treatment. And two of my co-authors, Drs. Deal and Duick, are here in the room today, who were the lead statisticians on this study. I'm also pleased to note that the results of this trial are being published online today in JAMA, simultaneous with this session now. And as a final note before I start, I would note that, like the prior study, this study was also funded both by public funding from the NIH and from foundation funding from ASCO, again underlining the importance of these mechanisms for funding important patient-centered research. Oops. Symptoms are common, such as nausea, pain, and fatigue, among patients with metastatic cancer, but unfortunately often go undetected by doctors and nurses until they become severe and physically debilitating. This is because between visits, patients are often hesitant to call the office until problems become severe. And even at clinic visits, amidst many competing topics and limited time, symptoms are often not fully communicated between patients and their doctors and nurses. So we've identified a communication gap. We wish that doctors and nurses were in more systematic communication with their patients about symptoms. We hypothesized that having patients report their own symptoms using an online system, with this information conveyed to their clinicians, would prompt those clinicians to intervene earlier, thereby improving symptom control and downstream health outcomes. This is a web survey. This is a web survey system that we developed and taught patients to use for self-reporting symptoms in this trial. Patients could use it from home between visits and also in clinic waiting areas prior to seeing their oncologist. The system automatically triggered email alerts to nurses anytime a severe or worsening symptom was reported by a patient, such as in the example on this slide. And the nurse could then use this information to take clinical actions between visits. In addition, the system generated reports showing the trajectory of symptoms over time that oncologists could use at visits to lead discussions with their patients and to guide symptom management. We tested this web-based self-reporting system in a clinical trial in which 766 patients receiving treatment for metastatic cancer at Memorial Sloan Kettering Cancer Center were randomly assigned to one of two arms. In an intervention arm, patients used the web-based system to self-report 12 common symptoms prior to visits in clinic waiting areas and between visits from home. Weekly emails were sent to patients reminding them to report. Email alerts were triggered to nurses for severe or worsening symptoms, and reports showing symptom trajectories were printed for oncologists at visits. The control arm of the study was standard symptom monitoring, consisting of usual discussions at visits or calls between visits at the discretion of patients. Patients remained on the study until discontinuation of all cancer treatment, hospice, or death. And then we measured a host of clinically meaningful outcomes. Compared to standard care, patients who self-reported symptoms experienced multiple statistically significant clinical benefits. 31% of patients experienced better quality of life and better physical functioning. There was a 7% reduction in emergency room visits. And patients were able to remain on potentially life-prolonging chemotherapy for an average of 2 months longer duration. But perhaps the most notable finding in this study is that compared to standard care, median overall survival was 5 months longer among patients in the self-reporting arm, which is almost a 20% increase in survival time for these patients. Another way to think about this is 5-year survival. At 5 years, 8% more patients were alive in the self-reporting group. Why might this survival benefit have happened? There are 3 potential drivers supported by evidence from this trial. Number 1, this system yielded more responsive care. It alerted clinicians in real time about symptoms as they emerged. It prompted clinicians to early action, to manage problems before they caused serious complications. Number 2, by controlling symptoms better, this system kept patients more physically functional and kept them from becoming deconditioned or immobile, which we know from multiple prior studies has a strong association with better survival. And number 3, this system enables better management of chemotherapy side effects. In oncology, we often are limited in our ability to give life-prolonging treatment because people don't tolerate it well. Being able to administer treatment longer can be beneficial, and in this study, patients who are self-reporting received 2 months longer duration of chemotherapy. We are involved with ongoing work testing the next generation of systems to make it easier for patients to communicate with their care teams. We are conducting national studies to figure out how best to integrate these tools into oncology practice. And we are building similar tools to improve our understanding of patient symptoms in cancer drug development. So in conclusion, integration of patient-reported symptoms into care for patients with metastatic cancer is associated with clinically meaningful benefits, including quality of life and overall survival. This approach should be considered for inclusion in standard symptom management as a component of high-quality cancer care. Thank you very much.
All right, that was terrific. I think all of you know Dr. Hal Burstein, who has been a fixture at this podium for many years and is the current chair of ASCO's Cancer Communications Committee. And Hal, I'd like to ask you for some more comments.
Thanks, Rich. So this is an exciting and compelling study because it shows that caring for patients improves patient care. And it validates something that we all feel but rarely have evidence for, which is that patient-focused, team-based medical care can improve outcomes in a measurable and meaningful way for our patients. On a daily basis, we all face challenges How do we communicate with our medical team? How do we communicate with patients? Many of us still carry beepers, which were very cutting edge in the 1970s, and we've struggled to integrate some of the newer communication platforms that are widespread in how all of us communicate with friends and colleagues and family into active medical care. So this study was an opportunity to look at what such an intervention might do and to actually measure whether that would have an impact. And to my mind, it's remarkable that a relatively simple intervention that allows us to meet patients where they are and allows them to communicate to us without the traditional barriers of having to call an office or other things that people might be discouraged to do can reduce ER visits, improve quality of life, and incredibly actually improve overall survival. Now, if this was a new drug, if this was ipadolizumab or Googleitinib, we would be immediately asking two very powerful questions. How do we implement this into our practice? And what's the mechanism of action? And Ethan just spoke to some of the ideas about the mechanism of action, but I think this is an area we'd really like to understand better. Is it because we truly have lowered that threshold that might keep people from communicating? Is it because we had more timely interventions to alleviate symptoms or prevent problems? Is it because we supported people better and allowed them to get more effective therapies, or perhaps allowed them to feel they could say no to therapies that might not be so good for them? This is a very important question because it obviously has implications for where we want to put our focus. And you've already seen in his plans for the future some ideas to make this even more accessible and mobile for people. The second is, how do we integrate this into our practice? And I would remind you that truly, if this were a drug that had a survival advantage of this magnitude, it would be retail priced at hundreds of thousands of dollars. There are very few drugs that have long-standing survival benefit. And so we don't have those kinds of resources typically to invest in the kind of electronic communication, nursing care, and other things that made this a reality on a day-to-day basis for these investigators. So a big challenge for our clinicians is going to be, how do we implement such systems? How do we integrate them into electronic health record keeping that we are currently using? And how do we provide the medical team power in the way of doctors and nurses and other supportive providers to make this work? But that's a good challenge and a good problem to have. And I know that as these data have circulated, it's been immensely gratifying to the oncology community to truly imagine that the kind of things we really believe in, patient-focused care, paying attention to their symptoms and intervening early, is really helping these people consume fewer healthcare resources in the way of ER visits, allowing them to feel better, and now we have proof helping them live longer.
Great. Thanks, Hal. Ethan, I have to tell you that this study, I feel validates a practice that I always had in teaching the medical residents. So, the medical residents would collect all the information about their patients, the lab results, the scan results, the biomarker results. They'd present everything to me as the attending physician. Sometimes they never quite figured out what was wrong with the patient. And my response to the residents always was, when all else fails, talk to the patient. The patient will typically tell you what's wrong with them. And I think this study clearly illustrates that. And these frequent touches between the patient and their healthcare providers obviously can make a huge difference in their outcomes. So we'll go on to our final presentation today that will discuss results from a phase 3 clinical trial evaluating the PARP inhibitor, olaparib, against standard chemotherapy for women with BRCA-related advanced breast cancer. I'd like to introduce Dr. Mark Robson, who's Clinical Director of the Clinical Genetics Service and a medical oncologist at the Memorial Sloan Kettering Cancer Center in New York. Mark.
So, thank you, Dr. Shilsky, and good morning, everybody. On behalf of my co-authors, we'd like to thank the program committee for the opportunity to share the results of Olympiad, which is an international open-label randomized phase 3 trial of the PARP inhibitor olaparib against standard chemotherapy in patients who have metastatic HER2-negative breast cancer and a germline BRCA mutation. So the poly-ADP ribose polymerase family of enzymes, a couple of the members, especially PARP1 and PARP2, are involved in the repair of a specific type of DNA damage, namely breaks to one of the two strands of the DNA. Now, BRCA1 and BRCA2, on the other hand, are involved in repair of another kind of DNA damage, double-strand breaks, through a process that's called homologous recombination repair. And it turns out that if you inhibit PARP1 and PARP2, you create damage that requires the homologous recombination pathway to fix it. And so cells that are defective in homologous recombination, and those that have BRCA mutations are the best known example of that, are actually sensitive to drugs that inhibit PARP. So visually the way this works is that if you have single strand break damage, normally in a cell that has both PARP activity and BRCA activity, the PARP takes care of the single strand break. If you give a PARP inhibitor, the enzyme gets stuck on the DNA, creates a lesion that has to be repaired by BRCA1 and BRCA2, but in a normal person, somebody who has BRCA1 and BRCA2 function, it gets fixed. The problem is, in a cancer from a patient who has an inherited BRCA mutation that doesn't have BRCA1 and BRCA2, when the PARP gets trapped, that lesion can't get resolved, and the cancer cell dies through something that's called synthetic lethality. PARP inhibitors have already been improved for the treatment of ovarian cancer in patients with mutations in BRCA1 or BRCA2, and recently in other circumstances. And there have been a couple of small studies that have suggested that breast cancer in BRCA mutation carriers could also be responsive to PARP inhibitors. And so this was, as I said, a multi-center trial that was designed to specifically assess whether or not PARP inhibitors could improve progression-free survival in this group of patients. So you all spend a lot of time looking at study schema, and I don't want to walk through this in detail except to point out that everybody had centrally confirmed deleterious mutations in BRCA1 or BRCA2, that they had received 0 to 2 prior chemotherapy lines for metastatic disease, but they all had received anthracycline and taxane therapy, and if they were hormone receptor positive, they had received at least 1 endocrine therapy and progressed. Prior platinum was allowed on the study, but if they had received it as adjuvant or neoadjuvant, it had to have been 12 months, and if they had received it in the metastatic setting, they could not have progressed. Patients were randomized 2 to 1 to receive olaparib tablets at 300 milligrams twice a day. This is different than the FDA-approved capsule formulation, which is 400 milligrams twice a day. That is 8 capsules twice a day, and so the two tablet twice a day formulation was developed for patient convenience. And the control arm was a pre-declared choice by the physicians of one of 3 regimens that are standard in this circumstance. And patients were treated till progression and monitored for PFS as the primary endpoint, with a number of secondary endpoints as shown there. This was a pre-planned statistical analysis to be done at 230 events. There were 205 patients in the olaparib arm and 97 patients in the chemotherapy arm. With that, we had a 90% power to detect a significant difference, and that would have corresponded to approximately a 37% improvement in progression-free survival. The patients were young because they have BRCA mutations. Interestingly and importantly, about 1/3 of the patients were non-white, mainly coming from Asia, roughly split between BRCA1 and BRCA2 mutations, and roughly evenly divided between hormone receptor positive and triple negative disease. Most of them had received prior chemotherapy for their metastases, and a little bit more than 1/4 had received prior platinum therapy. And this is the kind of primary endpoint, which was progression-free survival by central radiologic review. And the olaparib treatment was superior to chemotherapy with a hazard ratio of 0.58, so an approximately 42% improvement in progression-free survival. The confidence interval you can see there, and it was highly statistically significant. Generally, olaparib was pretty well tolerated. There were fewer grade 3 or greater side effects in the olaparib arm than in the chemotherapy arm. There were fewer treatment discontinuations due to toxicity, and there was less neutropenia. The main side effects were nausea, which was usually mild, and only about 1/4 of the patients required antiemetics. Anemia, which did result in transfusion in a proportion of patients, and then fatigue. So this is the first phase 3 study that's shown an advantage of a PARP inhibitor over standard of care chemotherapy in breast cancer patients with a BRCA mutation. It was generally well tolerated, with less than 5% of patients discontinuing treatment for toxicity and a lower rate of grade 3 or greater side effects. We did measure global health-related quality of life, which we will present this afternoon. And it is our opinion that olaparib could be an effective treatment option for women with BRCA mutations in metastatic HER2-negative breast cancer, including, importantly, women with BRCA mutations in triple-negative disease. Thank you very much.
Thanks. Thanks a lot, Mark. It turns out that when Dr. Hayes is not busy being president of ASCO, he's a darn good breast cancer doctor. So I'd like to turn to him for some comments about this study.
Thanks, Rich. It's true. Starting Monday at noon, I go back to my real job, which is taking care of patients with breast cancer. And this is really a major step forward for us. I said earlier there were fundamentally 3 or 4 themes that are running through the abstracts we're presenting overall at this meeting. One is immunotherapy, which we don't have in the plenary session this year, but for those of you who did not hear the Karnowski Award, first, you should have, and second of all, I'd urge you to go watch it, because Carl June discussed the CAR-T approaches, and it was very much an oh wow kind of thing, in my opinion. The second is survivorship, and I think we heard 2 very nice talks today about trying to personalize our care for patients who are actually surviving with cancer. And both Drs. Grothy and Bosch did a great job, I think, showing how we're trying to get away from one size fits all. And the third is the so-called precision medicine. And frankly, in breast cancer, we've been doing precision medicine for about 120 years now, first against the estrogen receptor and second against HER2. But for patients whose cancers are negative for those 2 things, we've had chemotherapy, which is not very precise. And this is one area that we've really had to work hard on. This also represents a major step forward, in my opinion, in translational medicine. The concept of synthetic lethality and PARP within DNA repair has been around for actually 20 years. Yeah, probably. But it took some really smart people to put 1 and 1 together and get 2 or 3 or 4, and now we have the PARP inhibitors. And Dr. Robson's paper, I think, is a really major step forward in breast cancer. There are a few issues you all need to emphasize. One is these patients all had germline inherited BRCA1 or 2 mutations, so this is not for the general population yet. And I think it's almost as much a proof of principle as it is practice changing, and that is these drugs do work in breast cancer if we're smart and if we're precise, and that's a great step forward. The second is it leaves a number of questions, but probably most important here is not a question, but that if we are precise with what we do, this is a drug that has fewer side effects and works better than what we've done in the past. That's what we're trying to do for our patients, make them feel better and make them hopefully live longer. We don't know this data yet, but I think that's terrific. Some of the other questions we have in the field are, well, instead of comparing this to chemotherapy, what if we add these to chemotherapy? And there are trials ongoing now, and I think Dr. Robson would agree with me. This is really just the first step in our efforts to move forward with this class of drugs, but I think that's one of the big questions. The second, obviously, is instead of waiting until patients are relatively far down the road, 3/4 of these patients had already received chemotherapy in a metastatic setting. What if we move this earlier into the metastatic setting, or even more exciting, perhaps, into the adjuvant setting? And I believe you will see trials like that beginning to be reported in the next year or 2, or at least conducted. Finally, there are 2 major issues that we all are concerned about, probably not in this group of patients, but one of those is long-term toxicities. These drugs inhibit DNA repair. In theory, inhibiting DNA repair could be quite dangerous because we like to have DNA get repaired when it makes mistakes. We're trying to inhibit DNA repair in the cancer cells, but it may do that in normal cells too, and there have been a few cases of secondary leukemias, mostly in the ovarian setting. I think we have to be cognizant of that. It's not a big issue. It's not even established yet, in my opinion. I don't know, Mark, if you feel differently, but I think it is a concern, so we don't want patients to just suddenly start grabbing this stuff, especially in the curative setting. And the final thing to me is the sad news, in addition to the happy news, is that those curves still come together. We need to understand what the mechanisms of resistance to these drugs are. Even when they work, the curve still ultimately came back together again. And that goes back to using them in different ways, clever ways, perhaps combining them with other sorts of therapies. But I believe, and I give my wholehearted congratulations to Dr. Robson and his colleagues, this is a really big step forward in breast cancer.